Thanks everyone for joining early. We'll start in a couple of minutes. Good afternoon, everyone. Before I introduce our speaker, I have a few housekeeping announcements. This CME activity is sponsored by the Hawaii Consortium for Continuing Medical Education, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing grand rounds for CME attendance purposes. As a reminder, evaluations are required for CMEs. At the end of today's talk, Michaela will put the evaluation link in the chat box. You can also find the link anytime on our website or our email advertisement. Your comments are very important to the planning committee and will be used to help plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are disclosing to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. Dr. Hino has disclosed that he has no relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. I have another quick announcement to make about the HCCME. It is actually going to be closing its doors as of December 31st of this year. So starting in January, our CMEs will be through the Queen's Medical Center. I do recommend that all of you who've been attending grand rounds on a regular basis, if you want to claim your CMEs, maybe you should go to the HCCME website and claim your CMEs for everything prior to next year. So at the end of today's talk, Michaela will also give you a link to the HCCME website so you can claim all your CMEs. Okay, now on to our speaker. Dr. Garrett Hino Jr. is an infectious disease pharmacist working with the Hawaii State Department of Health on the Healthcare Associated Infections, or HAI team. Dr. Hino graduated from the Daniel K. Inouye College of Pharmacy and completed both a PGY1 practice pharmacy residency at the Daniel K. Inouye College of Pharmacy and a 2-year infectious disease pharmacy fellowship at the Loma Linda University Medical Center. After completing his ID fellowship, he received board certification in infectious diseases and joined the HAI team at the Hawaii State Department of Health. He leads antimicrobial stewardship efforts and addresses the emerging threats of antimicrobial resistance. Please join me in welcoming Dr. Hino.
Thank you so much for that introduction. And just thank you for having me today to present overview and updates of COVID-19 outpatient therapeutics. So for some learning objectives today, I hope that you are able to assess patients for risk factors associated with severe COVID-19 outcomes after today's presentation, evaluate COVID-19 outpatient therapeutic effectiveness against current circulating COVID-19 variants, identify and locate available COVID-19 outpatient therapeutics in Hawaii, and also compare COVID-19 therapeutics and distinguished products for treatment and prevention. Again, I do not have any financial interests or relationships to disclose. And now going into some backgrounds and risk factors. So as you all may know, there are several outpatient therapeutic options that are available for non-hospitalized adults with mild to moderate COVID-19 and who are at high risk for disease progression. But many of you wonder who is at high risk for disease progression. So here is a nice chart that kind of describes that age is kind of an important risk factor to consider as COVID-19 death risk ratio increases as age increases. The death risk ratio for certain comorbid conditions are shown below, but in the next chart, we see that the death risk ratio increases as the number of comorbid condition increases. So who should really be receiving these medications? Here is just a summary of a list of conditions with evidence that are higher risk for severe COVID-19 outcomes. described here, and this is a detailed list for your later referral. So what I really wanted to touch upon is these updates on the circulating variants as the pandemic evolves. So, and as you see in this chart, there are many subvariants in the Omicron lineage or sublineage. We see that BA.5 is slowly decreasing with an increase in the subvariants BQ.1 and BQ.1.1. Unfortunately, these two variants have been showing resistance to certain therapeutics, as I will show in the next slide. So I won't go into too much depth, but wanted to bring some awareness of the variants that are currently circulating in the US. Unfortunately, BQ.1 and BQ.1.1 have shown resistance to therapeutics such as bebtelovimab and also Evishield, which is our only PrEP agent for prevention of COVID-19. With this information, the FDA no longer authorized bebtelovimab for use, and we will likely expect similar recommendations for Evishield in the near future. So this chart is something that I created for yourself for later referral, but this is just COVID-19 outpatient therapeutic effectiveness against circulating variants in the US. As you can see here, bebtelovimab, which is the last row, is not authorized for use. And at the top row, you see all the different variants, and these are subject to change as the pandemic evolves and subvariants arise. But really, this chart is reflective of the variants currently circulating in the US based on the charts in the previous slide. We also have a Hawaii version of the COVID-19 data report that obtains the proportions of the circulating variants in Hawaii. A report is generated for each of the islands to provide awareness of the circulating variants identified. So highlighted in red, you see are the variants that are resistant to bebtelovimab. As you can see, these variants have been increasing over time, and therefore we expect that our numbers will eventually match similarly to the US proportion of these variants. So based off our trends, we see that Hawaii data for the proportions of these COVID-19 variants tend to lag a couple weeks and are not truly reflective in real time in comparison to other jurisdictions in the mainland. So a summary of the circulating COVID-19 variants. So there has been shown that there's 80% resistance nationally to Evishield. So it's important to educate our patients that breakthrough infections are possible, advise patients to have a treatment plan in place, and to seek timely medical attention if symptoms occur. And also, the FDA did announce that Evishield is the only agent that is FDA authorized for SARS-CoV-2 PrEP, and people who are not expected to mount an adequate immune response to COVID-19 vaccination or those with contraindications for COVID-19 vaccines. Therefore, the panel does continue to recommend the use of tixagevimab plus selgavimab or Evishield as PrEP for eligible individuals. And this recommendation may change if the prevalence of resistant subvariants increase. Luckily, we still do have effective therapeutics such as Paxlovid, Lagavrio, and Veklury, as these are expected to retain activity against all circulating variants based on preliminary data and sequence analysis. To the right, we see that there are resources for your later referral. This includes the CDC COVID-19 data tracker, as well as the Hawaii COVID-19 data reports. So now I kind of want to show you that our Department of Health has created this COVID-19 summary metric that can be found in the link below. And this kind of creates this nice chart and summary of current cases, number of cases, also a summary of COVID-19 deaths in Hawaii up until now. So we see here that we see a decrease in deaths associated with COVID-19 in comparison to the spikes of September 2021 and January of 2022. However, we must prepare ourselves in case of another surge and identify treatment options available, especially in populations that are at high risk for severe disease progression. As you can see highlighted below, age continues to be a huge risk factor for severe COVID-19 outcomes, including death. In comparing these two charts, we observe that, again, age is an important risk factor to consider, but we do have outpatient therapeutics available that can help with reducing the amounts of COVID outcomes, which include hospitalization and deaths. Now moving on to COVID-19 outpatient therapeutics. So this is just a summary of COVID-19 preventative agents and treatments, but for the purposes of this presentation, we will be focusing on the highlighted portion, which includes Evusheld, Paxlovid, Lagavrio, and Veklury. So we do have several outpatient therapeutic options available, including an option for prevention, which I will discuss more in detail in the later slides. Unfortunately, the FDA did announce recently on November 30th that bebtelovimab is not currently authorized in any US region due to the prevalence of COVID-19 variants that are resistant to this therapeutic option. So we're really left with 3 treatment options and 1 prevention. So this is just a summary chart of clinical trials and its estimated efficacy. As you can see here, Paxlovid and Veklury are both preferred agents, showing 88 and 87% reductions in hospitalization and deaths, respectively. Lagavrio is an alternative due to the evidence of 30% reduction in hospitalization and deaths. So you may be wondering, where can I find these COVID-19 therapeutics? So there are 2 locators, and this can get confusing, but I will slowly walk them through you. So there's a test to treat locator, and there's a COVID-19 therapeutics locator. So this test to treat locator is more so both for providers and patients, just so that they can identify test to treat locations, which is locations that have the capability of providing testing services, a provider consultation, and medication dispensing all in one location. And we have over 20 locations that is able to do that. And over 250 locations have been established and able to fill a prescription for COVID-19 medication. For the COVID-19 therapeutics locator, this may be helpful for providers to see I guess the shipments of US government procured COVID-19 therapeutics under the FDA EUA. But unfortunately, as these therapeutics slowly transition to commercial market, therapeutic availability may not be reflective on this locator. Here is a COVID-19 outpatient therapeutic clinical decision aid for your later referral, but it's just to help yourselves to kind of streamline the process of diagnosing and determining if patients meet eligibility to receive COVID-19 therapeutics. And now I'm going to go into depth of the available COVID-19 therapeutics. So first covering the oral options. So first I'll talk about Paxlovid, or ritonavir boosted nirmatrelvir. So quickly, Paxlovid is a combination of 2 drugs, with one drug being an active drug and the other as a pharmacokinetic booster to increase the concentrations of the active drug. Paxlovid works together to inhibit a part of the viral replication process, which prevents the virus from replicating further. It's indicated for adult and pediatric patients 12 years and older, weighing at least 40 kilograms, with a positive COVID-19 viral test, and those who are at high risk for progression to severe COVID-19. So the 2 medications are packaged separately, but must be co-administered together, initiated within 5 days of symptom onset, and all tablets must be taken together twice daily for 5 days. There are 2 different types of dosing. There's a standard dose and a renal dose. The renal dose is for patients with eGFR 30 mils per minute to less than 60 mils per minute. Some adverse reactions described from the package inserts include dysgeusia, diarrhea, hypertension, and myalgias. A major warning associated with Paxlovid is the drug-drug interaction with many drugs due to the ritonavir component of the medication. Collaborating with pharmacists and identifying resources that can help identify potential drug-drug interactions is important to ensure your patient's safety while taking this medication. As you may know, there has been CDC health advisories that have been released on COVID-19 rebound. And this was released back in May of 2022 that described COVID-19 rebound after Paxlovid treatment. So COVID-19 rebound symptoms generally occur between 2 and 8 days after initial recovery, usually characterized by the recurrence of COVID-19 symptoms or a new positive viral test after having tested negative. Patients who have experienced COVID-19 rebound have had mild illness, and there has really been no reports of severe disease. More data has been made available to show that COVID-19 rebound is likely not associated to any drug class, as this phenomenon was also observed after courses of Ligavrio. It is important to educate patients to complete their course of Paxlovid to prevent the development of resistance, and to educate patients that Paxlovid treatment helps to prevent hospitalization and death due to COVID-19. These are just general recommendation for healthcare providers. Overall, there is no evidence that additional treatment for COVID-19 is needed for COVID-19 rebound. And longer treatment courses of Paxlovid are not authorized by the current EUA. And there are also insufficient evidence on the efficacy of administering a second dose. However, a 5-day course of Paxlovid can be prescribed if the patient gets a subsequent COVID infection, meaning a patient could receive multiple 5-day courses of a therapeutic, but not for the same infection. They would have to be discrete episodes or illnesses. It is important to note that the EUA state that the treatment is not to exceed 5 consecutive days. And the EUA does not provide guidance, unfortunately, on the waiting period before a subsequent Paxlovid or Ligavrio course that can be prescribed. Here, I wanted to provide some resources to you all to access for later reference that may be helpful for you when prescribing Paxlovid to your patients. So I kind of wanted to touch upon Ligavrio. It is an alternative medication, so I won't focus too much on it, but it does work similarly to Paxlovid as it inhibits a part of the viral replication process. It's not commonly utilized as this is linked with high toxicity and low efficacy, as I will be describing in the later slides. Again, this is indicated for treatment of mild to moderate COVID-19 for ages 18 years and older with a positive COVID-19 test, high risk for progression, and it's an alternative when COVID-19 treatment options approved or authorized by the FDA are not accessible or clinically appropriate. Some of the warnings and precautions include embryo-fetal toxicity, hypersensitivity reactions including anaphylaxis, and bone and cartilage toxicity. Here is an update to the fact sheet for molnupiravir. Again, viral rebound was also observed with Ligavrio use, and therefore it's described that this is not likely due to any specific medication. So now going on to intravenous COVID-19 therapeutics, which include Veklury or remdesivir. So it is an intravenous antiviral that attaches to the COVID-19 RNA template and overall inhibits viral RNA synthesis, shown in number 5. It is indicated for adult and pediatric patients ages 12 years and older, weighing at least 40 kilograms, for patients who are not hospitalized, have mild to moderate COVID-19, and are at high risk for progression to severe COVID-19. For the purposes of this presentation, I'll focus more on the outpatient recommendations, but Also note that it is indicated for hospitalized adult and pediatric patients for the treatment of SARS-CoV-2. So for outpatient dosage and administration, it's to be initiated within 7 days of symptom onset. For non-hospitalized patients, the dose is a 200 milligram loading dose on day 1, followed by 100 milligrams IV on days 2 and 3. And it's to be administered in a setting where severe hypersensitivity reactions can be managed. Patients should be observed for greater than or equal to 1 hour after infusion as clinically appropriate. There are some adverse reactions associated with this. Lab abnormalities such as liver enzyme elevations have been described. There are also nausea and headaches, adverse reactions described as well. Lastly, I wanted to touch upon the intramuscular injection for COVID-19 prevention, which is Evusheld. It's a combination of tixagevimab and selgavimab. So the mechanism of action of Evusheld, it binds to non-overlapping portions of SARS-CoV-2 spike proteins and prevent the virus from interacting with the human ACE2 receptor. The two medications are synergistic, therefore it is important to give them both at the same time. Unfortunately, we do see a large prevalence of circulating variants that are resistant to Evusheld, so we may see further recommendations from the FDA to remove authorization of this medication. It is indicated for pre-exposure prophylaxis of COVID-19 in adult and pediatric patients ages 12 years of age and older, weighing at least 40 kilograms. It's not a substitute for vaccination in individuals for whom COVID-19 vaccination is recommended. So it's indicated for patients that are not currently infected with COVID-19 and immunocompromised due to a medical condition or receiving immunosuppressive medication and may not mount an adequate immune response to COVID-19 vaccine, or individuals unable to receive COVID-19 vaccine due to a history of severe adverse reaction to the vaccine. Here is an extensive list of patients that may be considered for Evusheld and kind of fit the immunocompromised definition. And this is for your later referral. For the dosage and administration, it's given as 2 separate intramuscular injections every 6 months. Again, it's to be administered in a setting where severe hypersensitivity reactions can be managed, and patients should be observed for greater than or equal to 1 hour after infusion as clinically appropriate. Here's a step-by-step process for your later referral. But just note that these are 2 separate injections given both at the same time at different injection sites, preferably one in each of the gluteal muscle, one after the other. Some adverse reactions include headache, fatigue, and cough. And then warnings and precautions. There is hypersensitivity, including anaphylaxis described. Risk of cross hypersensitivity with COVID-19 vaccines. So Evusheld contains polysorbate 80, in which some of the COVID-19 vaccines have, and is structurally similar to polyethylene glycol, an ingredient in other COVID-19 vaccines. For individuals with history of severe hypersensitivity reactions to a COVID-19 vaccine, they recommend to consider consultation with an allergist or immunologist prior to Evusheld administration. There has been also described clinically significant bleeding disorders and cardiovascular severe adverse events. So I wanted to highlight important resources that may be helpful for yourselves. So the CDC created a COVID-19 action plan, and this is something that you may want to sit down and talk with your patients, as this is a guidance to help individuals put together a COVID-19 plan so that all the information needed is on hand if a person or a member of their household gets sick with COVID-19. So I included the link here to the template. The Disease Outbreak Control Division in the Hawaii State Department of Health created this webpage for providers and pharmacists to be updated on the evolving COVID-19 pandemic, and includes information on circulating variants, updated therapeutic recommendations, and resources that may be helpful for you. Here are just some of the listed references and resources that providers may have access to on this webpage. So for updates on COVID-19 therapeutics, so they provided a general timeline of COVID-19 vaccine and therapeutics that will likely transition to the commercial market. And the commercialization of these products will likely happen over the next year as COVID-19 funding is being depleted. So we hope to see some guidance from our federal partners on initiatives that can support underserved and underinsured patients to provide equitable access to these life-saving medications. And again, bebtelovimab is not authorized for use anymore due to the prevalence of bebtelovimab resistance. And then lastly, before closing out, I wanted to provide some resources in preparing for the triple threat, which is RSV, influenza, and COVID-19, kind of being described now, especially during the winter time. So here I wanted to just provide some IDSA and CDC webinars for your later referral. I believe they're like an hour to an hour and a half each that kind of describe, the triple threat of RSV, flu, and COVID-19, how to differentiate between those, and also how to prepare for them in the near future. And then I just wanted to thank you all for having me here today, and thank you for listening and open to any questions.
Thank you so much, Garrett. I'm just looking through the chat, and there is a question from Mia. Are there any updated recommendations or data on crushing Paxlovid or molnupiravir?
Yeah, actually, that's a great question because I actually had similar thoughts on that. I think on the CDC website, they said that it wasn't recommended, but there's also evidence to describe it's okay to be crushing Paxlovid in those cases too. And I think there's a reference on there from my brief review of the CDC guidance, if that's helpful.
Yeah, Garrett, this is Mia, because this is becoming a real issue for our geriatric population in the facilities. I'm not aware of any of the facilities giving remdesivir, and so we are really struggling for the patients who can't swallow pills. So I did some lit search this past week when one of our geriatricians reached out to me. I didn't see anything updated. I'll go on the CDC website. I saw that same thing where it said, yeah, you shouldn't crush them. That's the package insert, right? And then, but I didn't see any references that really, they said, there was like this vague, you may be able to crush it, but there wasn't any real data on it, right? I'm really hesitant to say, oh yeah, go ahead.
Yeah, I know, and it's such a huge blow to remove bebtelovimab, and because that was so helpful for especially patients with difficulty swallowing, and it's a one-time dose, and with remdesivir, it's so difficult to coordinate outpatient administration of this medication for 3 consecutive days. I know that there's a lot of restrictions for that. So it's just a matter of, we have to get creative with the current therapeutics. And I agree. If I could get your email, I could definitely follow up with you on the side and really talk about more of the evidence that maybe kind of supports crushing Paxlovid, especially for the patients that have difficulty swallowing.
Sure. Yeah. And Dr. Tom, he did put the reference that I had seen as well, and I think probably the same one you saw in the chat. It just wasn't super convincing for me.
Yeah.
So, yeah, I will put, my email in the chat if that's okay, but it's
Yeah, of course.
H. Taylor at Queens. Thank you so much.
No, thank you. Appreciate the questions.
Thank you, Mia, for that great question. Any other questions from our audience?
And I think for everyone on the line, can I just add one plug? We are currently, right now, as we speak, standing up remdesivir outpatient therapy at Queens. And I think, as Garrett mentioned, logistically very difficult because it's 3 consecutive days of IV therapy. So right now, Kaiser also is doing it on a case-by-case basis, and we'll be offering at our West Oahu campus. And North Hawaii will be doing it case by case, but yeah, logistically, it's tough. It's hard to get patients in for 1 dose of IV, let alone 3, right?
Yeah.
So Mia,
No,
where do the patients go and how do you select who gets that?
Yeah, so been working with the COVID ops group and really looking at how do we prioritize patients right now for any patient who is tier 1 on the NIH prioritization list, meaning they are immunocompromised and very high risk. We are considering remdesivir if they have absolute contraindication to Paxlovid. So, I mean, we're now as we're getting more comfortable with Paxlovid, there are what used to be contraindications with certain meds, we're now much more comfortable to adjust doses or hold doses and monitor labs. So Paxlovid is still first-line therapy. And we will be offering it at the Queens West campus. The referral process is exactly the same as it was for bebtelovimab through our virtual urgent care. They'll be assessing the patients and determining with support from our infectious disease team, if needed, to make a decision on who's eligible.
And I wanted to add that I haven't heard anything in the pipeline in terms of COVID-19 therapeutics. So I'm anxiously awaiting for any help that we can receive, especially for, these certain patient populations with, special needs, especially in our immunocompromised population. We're seeing this increased resistance trend with Evusheld, and now we're kind of having our hands tied, unfortunately. So I wanted to just thank everybody on the call for their efforts. To your patients, it's really helpful. And as you can see, these are life-saving medications. So any effort towards your patients is really helpful. Again, thank you.
Yeah, I'm shocked actually that they haven't pulled Evusheld yet, but I think it's been this kind of lifeline for some of these patients. But we have been definitely, based on the updates in the recommendations, been counseling patients that their variant may be, the new variants are for sure resistant, and the prevalence of these newer variants are increasing in Hawaii. And then I was just recently on the IDSA call, and what's really starting to take hold in some centers again are convalescent plasma. They're really taking a look at that again as an option because there is really not a whole lot else in the pipeline, but that still is not being commonly used as of right now. So, and I see Dr. Tom had a question about pharmacies being low on Paxlovid. I've not heard that, Dr. Tom. I can tell you that our POB pharmacies have plenty in stock. And the reason I know that is because when bebtelovimab got pulled, I was like immediately reaching out to the pharmacy saying, hey, FYI, be ready. And so they have both bebtelovimab and molnupiravir, but I've not heard about the other pharmacies. The locator, I think that Garrett shared with us, that's a great way to check and see which pharmacies locally are carrying the drug.
Thank you so much, Mia and Garrett. Any other questions? If not, Michaela, could you please put the CME link into the chat box? And also, if you want to access your CME record, so the one that she just put in is for your previous CME records, but could you also put in the link for today's talk, Michaela? So for those of you who missed the announcement in the very beginning, we are transitioning because HCCME is closing down their doors as of December 31st. So starting in January, our grand rounds will get CME through the Queen's Health System. So we'll be getting new links and all of that, new information for you starting in January. Okay. Garrett, thank you again for a wonderful presentation and for a great discussion after. We really appreciate you sharing your expertise.
Thank you again for having me on this platform. It's really helpful to distribute and disseminate information. So thank you so much.
Great. Thank you.